Hello, and welcome to Clinically Significant, a new live Q&A series from the AMA EdHub. I'm your host, Jodi Abbott. Today, we'll be discussing a topic unknown to most physicians and patients, the climate impact of metered-dose inhalers. And I'm honored to be joined by Dr. Gregg Furie, Medical Director of Climate and Sustainability at Brigham and Women's Hospital. Our session will examine the complexities of the climate impact of metered-dose inhalers and provide practical changes that clinicians can implement while prioritizing patient care. But of course, your questions and contributions are what make this dialogue truly impactful. So we encourage each of you to join the chat, let us know where you're from, and share your questions and thoughts throughout our discussion. So with that, let's begin our conversation. Dr. Furie, is it all right with you if we keep these things conversational and use our first names?
Of course.
Great. Well, I admit I'm one of the physicians and patients who did not know about the climate impact of dose-metered inhalers. So let's begin with the basics. Can you review the prevalence of asthma and inhaler prescriptions?
Sure. So asthma and COPD are the two most prevalent respiratory conditions in the United States and worldwide. In the US, there are about 28 million people with asthma. That's about 1 in 12 of the total population. And we know that this disproportionately affects Black populations. And there are about 14.2 million people in the United States living with COPD. The best data we have comes from 2020, and that shows that in that year there were 144 million metered-dose inhalers prescribed in the United States, which represents about 70% of all of the inhaled drug delivery devices that were sold that year.
Wow. So can you talk about the cruel irony of metered-dose inhalers for the patients who need them?
Sure. So the cruel irony of metered-dose inhalers is that these small devices, which are used to treat asthma and COPD primarily, make an outsized contribution to climate change, which in turn is having adverse impacts on the health of the very patients that we're using to treat these who are receiving these devices. We know that individuals with pulmonary disease like asthma and COPD are at high risk of negative health effects from climate change, particularly from their exposure to extreme heat, wildfire smoke, and aero allergens, all which are increasing in frequency and intensity as global temperatures rise. And the propellants in metered-dose inhalers, that's the part of the inhaler that forces the medication out of the device and into patients' airways, are potent greenhouse gases with thousands times the warming potential of CO2. It's estimated that emissions from metered-dose inhalers sold in 2020 are equivalent to the emissions produced by 500,000 cars driven for a year.
So dry powdered inhalers and soft mist inhalers have been identified as the environmentally friendly alternative to metered-dose inhalers. What barriers are preventing more widespread adoption of dry powder inhalers?
Yeah, so this is a really important issue. In the US, we rely heavily on metered-dose inhalers. Like I mentioned, in 2020, about 70% of all inhalers that were sold in the US were metered-dose inhalers. That percentage has increased over time. But that's unique to the United States. Many other countries, such as Sweden, Finland, rely much more heavily on dry powder inhalers. So they would use nearly exclusively dry powder inhalers. And in doing so, still achieve really excellent disease outcomes. So the question is, why in the United States are metered-dose inhalers so prevalent? And I'd say there are really three issues. One is just the culture of prescribing. So we in the United States have become very accustomed to prescribing metered-dose inhalers. It's not really based on any evidence that shows that one inhaled delivery device is superior to another. There are a couple of populations, particularly young children and those who can't generate significant negative inspiratory pressure to essentially pull the medication from a dry powder inhaler. Those are the only populations that really shouldn't be using dry powder inhalers. For everybody else, they are a very effective way of providing inhaled therapies. And in fact, many patients actually prefer them. So I think culturally, we tend to preferentially prescribe metered-dose inhalers. Part of that is due to the fact that metered-dose inhalers tend to be more available to us. And this is an issue of kind of access and cost. So in terms of access, as an example, there's some really important medications, in particular this combination of an inhaled corticosteroid and formoterol, which is the medication that is recommended by international guidelines to treat almost all patients with asthma. That medication is not available to us in the United States in a dry powder inhaler form, despite the fact that it's available throughout much of the world. It just hasn't been brought to market here. The other issue, I think, and many clinicians who are treating patients with asthma and COPD will be familiar with this, is that there just aren't many dry powder inhaler or soft mist inhalers available as generics or that are included as preferred agents on our patients' insurance formularies. And so as a
Mm-hmm.
consequence, they're essentially cost prohibitive for most of our
Mm-hmm.
patients. A good example would be albuterol. So there's a branded dry powder inhaler version of albuterol, but for most patients, that's far more expensive than the generic meter dose inhaler version. And so that's the one that we preferentially just prescribe. So I would
Mm-hmm.
say part of this is cultural, part of this is
Mm-hmm.
limited access to the medications that we really want to be using to provide high quality care to patients with asthma and COPD in a dry powder form. And the other is just the cost issue.
Wow. So there's sort of a series of sequential barriers that need to be
Exactly.
addressed.
Yeah. So it's
Yeah.
hard for
Yeah.
physicians who really want to be providing disease concordant care while minimizing environmental impacts. It's really challenging given the medications that are available to us in the United States and that are affordable to our patients.
Mm-hmm. So, what are some practical steps that physicians can take to try to minimize the climate impact of meter dose inhalers?
Yeah, so despite what I just said, there are
Yeah.
some very practical things that physicians in the United States can be doing in order to limit emissions
Mm-hmm.
from meter dose inhalers. And I want to just preface this by saying, as we think about this, we should always be prioritizing patient outcomes first. So that is the most important thing. If we're able to achieve that while simultaneously reducing emissions from our prescribing practices,
Mm-hmm.
then then that's an additional benefit. But really, patient outcomes come first, and that should be our number one priority. Um, so as we just discussed, dry powder inhalers and soft mist inhalers are associated with 20 to 30 times less environmental impact than meter dose inhalers. And that's largely because they don't contain a propellant.
Mm-hmm.
So when possible, choosing a dry powder inhaler or a soft mist inhaler instead of a meter dose inhaler can be really beneficial. Um, it's key that if we're going to be switching patients or anytime we're starting a patient on an inhaler, that we
Mm-hmm.
ensure that they know how to use that device properly. So as we begin kind of talking to patients about this, we
Mm-hmm.
need to make sure that we're ensuring that they have good disease outcome by knowing how to use their inhalers. Another, and this is probably the greatest opportunity for most clinicians practicing in the United States, has to do with how we prescribe albuterol. So albuterol, nearly all of the versions that are available to us in the outpatient
Mm-hmm.
setting contain 200 actuations of 90 micrograms of albuterol. But you can get that in different canister sizes. So there's a 6.7 gram, an 8.5 gram, and an 18 gram canister size. All of those, the weight is primarily due to the propellant. So as I mentioned, they all contain the
Mm-hmm.
same number of actuations of the same dose of albuterol. And so if you're prescribing the smallest weight canister, each puff has the lowest amount of propellant per dose or per inhalation. So you can more than halve the amount of emissions associated with your albuterol prescribing by going from an 18 gram canister to a 6.7 gram canister. And what we know is that if you look at prescribing data from across the country, the vast majority of inhaled devices that we send to the pharmacy are albuterol. They represent by far the
Mm-hmm.
majority of emissions associated with meter dose inhaler prescribing in the United States. So for many clinicians, this is a real opportunity.
Mm-hmm.
all this being said, we're moving away from using albuterol alone as a reliever therapy.
Mhm.
But due to some of the challenges of prescribing the alternate approaches to treating asthma and COPD, for the near future, we will likely continue to see a large amount of albuterol used in the United States. And so this is a real opportunity to reduce emissions from metered-dose inhalers. So prescribe the smallest canister possible. That's the 6.7 gram when it's available to our patients based on their insurance. The next strategy just has to do with reducing albuterol use in general.
Mhm.
And so, as I mentioned, the vast majority of metered-dose inhaler prescriptions that we send are for albuterol, but
Mhm.
we know that that patients with poorly controlled asthma use excessive amounts of their short-acting beta agonist or albuterol. And ideally, what we should be doing is better controlling those people's disease so they're not so reliant upon their albuterol. There are some strategies to achieve better control that will help reduce emissions, particularly using an inhaled corticosteroid or an inhaled corticosteroid in combination with a long-acting beta agonist in a dry powder form. However, that's not necessarily the standard of care right now. And so that can improve emissions for patients for whom we choose that strategy, and largely for patients for whom the preferred strategy of using ICS, and inhaled corticosteroid, and formoterol as a combination product is not available.
Mhm.
Um, the the other strategies include really avoiding prescribing albuterol in situations where it's not clinically indicated. We see a lot of albuterol prescriptions for people who have an upper respiratory syndrome or an upper respiratory infection with an associated cough or a post-viral cough syndrome. There's no data to show that albuterol is effective for treating those symptoms for those patients. And so we should just be avoiding prescribing it. And then lastly, I would say for patients for whom we have a suspicion of asthma or COPD, that should really be confirmed with pulmonary function testing before we prescribe any medications to treat those conditions, because there are many patients out there who technically don't have a diagnosis of asthma or
Mhm.
COPD who are likely using metered-dose inhalers and not receiving much benefit from them. And as I mentioned before, it's critical that our patients know how to use their devices correctly.
Right. We do have a couple questions in the chat. One of them, I think you might have answered, but I don't know if you want to expand upon it. Um, our questioner says, what advice would you give to physicians um, about the use of combination MDIs with corticosteroid and formoterol? Are there um, ways to optimize the prescribing the way that you've talked about for albuterol?
Yeah, so this is a tricky situation because this is
Mhm.
where what's being recommended by international and national guidelines in some
Mhm.
situations is not consistent with reducing emissions from meter dose inhalers. So essentially, there are two main propellants that are used in meter dose inhalers. One is called HFA 134, the other is called HFA 227. 134 has about 1,500 times the warming potential of CO2. 227 has about 3,500 times the warming potential of CO2. And that's the one that's used in all of the products that, in all of the ICS formoterol products. And so if we're looking to provide guideline concordant care, that generally means starting patients on an inhaled corticosteroid and formoterol combination.
Mhm.
In doing so, we are likely to increase emissions associated with that patient's care because it uses that more potent greenhouse gas as the propellant. And this is why I say the kind of reducing emissions should come second. We should just be prioritizing patient's care. So if ICS formoterol is the right medication for that patient, then by all means we should be prescribing it,
Mhm.
recognizing that it's having that it is having a kind of adverse effect on the environment. But that product is not available to many of our patients because currently it's not FDA approved as a reliever for patients with asthma. Um, and so many patients, it's just not available to them to use for what we call smart or uh, maintenance and reliever therapy. We're using the same medication as both maintenance and reliever. And because of that, it's almost a moot point for many patients, right? Then we start considering all of these second line approaches where we can start if we want to use a maintenance medication. Then there are many inhaled corticosteroids or inhaled corticosteroid and long-acting beta agonist combinations that are available in a dry powder form. So if Symbicort is not an option or any of the ICS formoterol combinations are not available to your patient and you still want to use maintenance therapy, then all of a sudden you have potentially have access to a number of dry powder inhalers that can be used in combination with an albuterol and inhaled corticosteroid combination as the reliever.
Okay, thank you. We do have another question in the chat. In your experience, how do patients feel about switching their inhaler type, particularly if you say that you think they should switch for environmental reasons? How does that go?
Yeah, so this is an interesting question, and I think it varies from patient to patient. There was a study that was conducted in the UK, and recognizing that the UK is different than the US, that specifically asked patients this question. They asked patients with asthma or caregivers of children with asthma how they would feel about switching their inhaler type for environmental reasons. And the majority said that they would be open to that. They would want to know that not surprising, that this alternative inhaler was effective, easy to use, safe, affordable. So reasonable questions, but in general, people in the UK seem open to this idea of using a different type of inhaler. In my conversations with patients, many are open to the idea. The challenge is always the kind of insurance issues, right? So we broach the subject, and then we have to send the prescription to the pharmacy to see if it's even an option. But I do tend to have this conversation with patients. Usually I frame it in around their specific disease by starting off saying, we know that climate change is having an adverse impact on the health of people with asthma or COPD, whatever condition that patient has. And paradoxically, the very medications that we use to treat these conditions are actually contributing to the climate crisis. There are alternatives. Is that something that you would want to hear about? So that's generally how I frame it. I think it's important to discuss this in the context of that patient's own disease and recognizing that climate change or acknowledging that climate change is potentially having an adverse effect on their health by exacerbating their respiratory condition.
I think it's super helpful to have guidance from you about how to talk to patients, because that just opens the door for physicians who are, caught in their usual script of conversations with patients. It's good to kind of take you out of that. We do have another question in the chat. Are you aware of any clinical organizations of physicians, nurses, PharmDs, respiratory therapists, or other groups who are advocating for different propellants with no or very low GWP to be used in these MDIs in the first place?
Yeah, so this is an important issue. So the hydrofluoroalkanes, HFA 134 and HFA 227, are not only used for meter dose inhalers. It's a group of chemicals that are used in air conditioning, refrigeration, and currently as an amendment to the Montreal Protocol. This is called the Kigali Amendment. It's an international treaty to essentially phase down the use of these hydrofluoroalkanes. As a consequence of that, access to HFAs is going to decrease over time, and that's likely going to increase the cost of using them, or it's going to increase costs for manufacturers who are trying to use these in meter dose inhalers. And so this has prompted a number of pharmaceutical companies to start looking for alternative propellants. And there are a few candidates that are out there right now, the so-called low or no global warming potential propellants, and they are likely going to come to market in the next few years. This has the potential to have a real impact on emissions associated with meter dose inhalers. And as we discussed, meter dose inhalers are critical for some patients because young children, people who can't generate appropriate negative inspiratory pressure, really rely on meter dose inhalers as their treatment approach. The concern about them is that we've been in this situation before. So people who have been practicing for a while may remember that back in the early 2000s, we transitioned from chlorofluorocarbon propellants to the current generation of HFA propellants. And as a consequence, medications like albuterol that had been generic, this transition allowed pharmaceutical companies to essentially put these drugs back on patent. And then for the next 2 decades, we had no generic form of albuterol. So the cost to both patients and the health system increased dramatically when we went through that transition 20 years ago. And there's a significant concern that the same thing is going to happen when we make this current transition from HFAs to these new low or near zero global warming potential propellants. So I think there are many people who are advocates of this transition, but from an environmental perspective, but the question is, how do we do it in a way that doesn't increase cost for patients and make access to these really kind of life-saving therapies limited by cost?
Yeah. Well, that's such an important question. And actually, you answered the same question was in the chat, so it was perfect because you answered both questions with the same answer. Yeah, it really is a barrier to moving forward for a lot of patients because the medication costs have become so profoundly impacting on healthcare debt and other medical debt.
Yeah, and unfortunately, I think this reflects a pattern that we see with inhaled drug delivery devices, which is that pharmaceutical companies have identified ways to really manipulate the patent and regulatory system in order to stifle generic competition and keep branded products as the only available options for patients for decades. And I worry that we're going to run into the same problem as all of the current generation of metered dose inhalers, many of which are generic, end up back under patent as the propellant changes.
Right. Are the dry powder inhalers generic currently, or are they under patent in the US?
So there are a few that are available as generic, but not many. And same with the soft mist inhalers, which tend to be the therapies that we rely on heavily for patients with COPD. There are just not that many generic options. And again, this has to do with the pharmaceutical companies' kind of practices that really stifle generic competition and and really have resulted in these exceptionally high prices for many of these inhaled devices. A big challenge is really that the lack of an affordable dry powder inhaler for treating asthma according to international and national guidelines. That's it's a real kind of impediment to providing high quality care for patients with asthma and doing so in a way that has minimal environmental impact.
I wondered if you could explain the opportunity you have in your role in climate change health and how you are able to utilize that impact to try to help address some of these issues upstream.
Yeah, so I do think, and this is important for, I think, the whole audience to know, is that as health professionals, we are a really trusted voice around kind of climate change and its health impacts, and have an opportunity to really influence policy. So there was a study that came out a number of years ago now that specifically asked patients, or it not just patients, it asked the population. It was a survey that asked, who do you trust most for information about climate change's impact on human health? And the number one trusted source were primary care doctors. So I think there's an opportunity both for us to educate our patients about their own individual risks from climate change, but also to recognize that we are able to speak about this issue in a way that's not politicized. We talk about it in the context of human health. And as a consequence, we're able to, I think, really move the conversation around climate change in a way that can drive effective climate policy. We're seeing more and more attention to the health consequences of climate change in international discussions about climate, such as at COP, the Conference of Parties that happens every year. So recognizing the influential voice that we have in this issue is really critical. And I think that can be more broadly about climate policy, but also about these specific issues. So I and some colleagues of mine have been discussing this with people at the state and federal level with the goal of really trying to move the needle on around this issue of kind of patents and regulations around inhaled drug delivery devices, both in order to find ways to make these devices more affordable for patients, but also do so in a way that reduces their environmental impact. And we're beginning to see some real action. Again, this has been kind of an invisible issue here in the United States. And I think what's been surprising to me is how when we bring this to the attention of policymakers, how much they really care about the issue, how much it resonates with them, and how eager they are to begin identifying potential solutions.
Yeah. A related question in the chat is about whether there's FDA and federal funding opportunities to support the research into some new innovations and potentially prevent the repatenting that.
Yeah, so I think it's a great question, and I think that's something that we're eager to know as well. And I think a lot of this does have to do with the patent and regulatory system, and how can we really prevent these practices that the pharmaceutical companies use to maintain patent protection over these devices for decades. We're already starting to see some action. So the Federal Trade Commission has been investigating this and looking into situations in which really kind of inappropriate patents are listed in something called the Orange Book. That's basically the running list that the FDA uses to determine whether or not a specific medication is under patent, and therefore whether or not they can approve generic competition. So there is some action happening at the federal level. I'm not necessarily aware of any funding to support this work at the moment. I wish there were more, not just around this issue, but kind of climate change and sustainability within the healthcare sector more broadly, because there's a lot of interest in this area at the moment, but I think it hasn't been met necessarily with the funding necessary to support the important research that we need to answer many of these questions.
Yeah. Well, with that, we come to the close of what's been an incredibly enlightening and enriching discussion. Gregg, thank you so much for sharing your expertise and insights with us today.
Yeah, it was my pleasure. Thank you so much for having me, and I appreciate you all bringing attention to this important issue.
To our esteemed audience, thank you so much for your active participation and thoughtful questions. Your presence has really made this conversation come alive. If you enjoyed today's episode and wish to stay updated on future live Q&A events, we encourage you to subscribe to our email list. Simply click the subscribe button below. And before we go, a quick reminder that this activity is eligible for CME through the AMA EdHub. Click the link in the Take Quiz tab to earn credit for this activity. This content is educational and informational for our informational purposes only and does not constitute medical or legal advice. The viewpoints expressed in this series are those of our participants and do not reflect the views and policies of the AMA unless otherwise indicated. Thank you again for joining us today, and we'll see you on the next episode of Clinically Significant.